All right. Hello, everyone, and thanks for being here this afternoon. So this is our June edition of Court Connects. So I'm Dan Egan, and one of the members of the board of directors. I'm here with Marianne Howie, who helps to co-coordinate the Court Connects sessions with us, who's having some video technology difficulties, but is here. And I'm really excited to have this session today. This is a talk that was given at Court and got a lot of great feedback. And so we wanted to bring it to this forum so that people could have another opportunity to hear it if you've heard it before or hear it for the first time and potentially watch it later. So this is Sticks and Stones, Microaggressions in the EHR, and we have a great team here to do this talk for us today. So I will introduce our speakers. So Dr. Mary McLean is APD and IRB chair at St. John's Riverside Hospital EM residency program in Yonkers, New York. She's also the New York ASAP Research and Education Committee liaison and a past All New York City EM resident education fellow. Her professional interests also include bias, diversity and inclusion, and cardiovascular, neurologic, GI, and OB emergencies. And Dr. Yomna Nassef is clerkship director at St. John's Riverside, where she leads multiple patient safety and quality measures, including spearheading the geriatric accreditation for their emergency department. She's active on the ASAP Communications Committee, as well as the Patient Safety and Quality Committee. And her professional interests include patient safety and quality, medical education, and research. And Dr. Evan O is clerkship director as well at St. John's Riverside. And he also serves as the ED site director for the St. John's Riverside Hospital Dobbs Ferry Pavilion. His professional interests include systems, operations, and resident education. So we are super excited to have them here with us today. And please feel free to use the chat. Marianne and I can certainly moderate that. And then we will have some time at the end for people to either ask questions directly off of mute or to put them into the chat box. And with that, I will turn it over to our team. Thanks.
Thank you very much for that introduction. I'm Yomna Nassef. Again, I'm the clerkship director at St. John's Riverside Emergency Department here in Yonkers, New York. The title of our talk today is Sticks and Stones, Microaggressions in the EHR. Our biggest goal in giving this talk is to raise awareness of this long-standing and universal issue. We want to put it in context of recent events such as the 21st Century Cures Act, and we want to provide remedies to check our own bias, change our language, teach our peers and learners, and mitigate potential harm that may come from microaggressions in the EHR.
All right. So first, we're going to define microaggressions and in particular, how they're relevant to the EHR. We're also going to take a couple of minutes to explain why this is all the more relevant in the setting of the 21st Century Cures Act. So what exactly is a microaggression? The formal definition is a comment or action that subtly and often unconsciously or unintentionally expresses a prejudiced attitude toward a member of a marginalized group, such as a racial minority. Microaggressions were originally described by Pierce et al. In the context of theories of race and racism as subtle, stunning, often automatic, and nonverbal exchanges which are put-downs. And Ong and Burrow in 2019 explained that the microstem is not there to imply insignificance of these exchanges, but instead to characterize them as commonplace daily exchanges. So we're going to start off by doing a little exercise. Now here you have a portion of an H&P, and there are actually 16 microaggressions in this first part of the H&P as shown on this slide. So take a minute and see how many you can find. Okay, so we'll go ahead and reveal them. Now, some of these might be surprising to you, but don't worry, we're going to go over all of these later on in the talk. And moving on to the next portion, Here, the next two sections of the H&P, and there are 4 microaggressions. So take another minute and see how many you can find. And I like what Dan did. Once you finish, go ahead and put in the chat box how many that you were able to find. Okay, let's go ahead and reveal them. All right. And we'll move on to the next portion. So in these last 2 sections, there are actually 11 microaggressions. So one last time, take a minute and see how many of them you can find. Too many to count. That's good. All right, let's go ahead and highlight the microaggressions. Okay, so in total, there were 31 in the entire document. And I'm sure there are lots of questions. You may be surprised by many of them, but we'll go over all of them in a little bit. Next slide, please. All right. So this word cloud depicts some of the more common microaggressions that healthcare practitioners use in the EHR. And we'll go through a few specific examples here. So a pan-positive review of systems. This implies that the patient has so many ROS concerns that they're being overly dramatic or that the reported symptoms are unfounded. Frequent flyer is one that's commonly used. A frequent flyer returns to the ED. This implies that the patient overutilizes emergency care for non-emergencies and that their concern is not serious. The patient admits to missing appointments. This implies that patients are guilty or deserving of blame. They refuse to cooperate with the exam. Implies that they're guilty, that they're being difficult. And finally, the patient is morbidly obese. Now, this one is a little bit controversial because even words that were once commonplace in medical terminology are increasingly being considered offensive. And keeping in mind that patients can access their charts, the layperson definition for morbid may be concerning. It means gloomy, unwholesome, grisly, or gruesome. And microaggressions can even include inappropriate inclusions or omissions of descriptors. And a few examples are including race or ethnicity when irrelevant, or omitting anatomical sex if you're unsure. And it's not even just words or discrete phrases, it's also the way we structure our sentences. This is especially true in more narrative portions of the EHR, such as the HPI. Clinicians often use terminology that identify their patients as their disease or disability. When you document a patient's medical history, it's important to remember that patients are not defined by their diagnoses. Person-first language puts the person before the disease and conveys in your EHR that the patient has a problem rather than is the problem. For example, the wording 50-year-old male diabetic vasculopath patient sends a different micro message than 50-year-old male with diagnoses of diabetes and vascular disease. And we recognize that the way physicians talk about and write our narrative assessments of patients is a product of many decades of medical culture. We're also aware that some of these phrases classified as microaggressions may be the quickest way to get the patient's information across in the EHR. It's a lot quicker to type or read vasculopath than patient with peripheral vascular disease. And the value we place on efficient documentation is evidenced by the increasing use of scribes in the ED. Those of us who work with scribes need to be aware of a few potential pitfalls. First, it's often very convenient to copy portions of previous notes into new documents in the interest of time. Scribes are also often exposed to ED vernacular, especially when observing interactions between ED team members. For example, the triage nurse may come up to you to give a one-liner about a patient and state that this is a frequent flyer. Remember that many scribes are future medical professionals who are eager to learn the lingo and are very impressionable. But it's becoming more and more important that we're at least aware of the possible downstream effects of the way we word things. And a big reason we need to be more cognizant of the way we word our documentation is the 21st Century Cures Act. The Cures Act enables patients to easily read their own EHRs, bringing into the spotlight the pervasive use of microaggressions in everyday medical language and documentation. The Cures Act was implemented in April 2021, and it made 8 types of notes immediately available to patients. The ones that are relevant to our practice include H&Ps and MDMs, imaging reports, and lab reports. Some exclusions include psychotherapy session notes and notes compiled for legal proceedings. And here I will hand it over to Dr. Nassef.
Thank you. So at this point, we're going to switch gears and talk about the evidence that's already out there regarding microaggressions in the EHR and how they might contribute to bias in your clinical decision-making and patient management. So the first thing I wanted to talk about was actually, I think, came out in January of this year, and the title is Examination of Stigmatizing Language in the Electronic Health Records. This was a cross-sectional study at a large urban medical center. And what they did was what they called natural language processing of approximately 50,000 notes by 1,900 clinicians. Their goal was really to just examine the prevalence of stigmatizing language in admission notes, patient and clinical characteristics that were associated with the use of such stigmatizing language. What they found was that it was present in about 2.5% of notes overall. It was present in almost 7% of notes for patients with diabetes, 3.4% of notes for patients with substance use disorder, and 0.7% of notes for patients with chronic pain. There was a much higher probability of use of stigmatizing language for patients who were underrepresented minorities, those with greater diabetes severity, most often due to using the word noncompliant. And what I thought was most interesting from an academic and educational perspective was that the less advanced a clinician was, so the lower their PGY level was, the more likely they were going to use stigmatizing language. So it seems that as they progressed in their educational training, they used less of this language, which is good and means that we're doing a good job when we're teaching our residents. The next study was in 2018. It was called Do Words Matter, Stigmatizing Language and the Transmission of Bias in the Medical Record. This was a randomized vignette study at an urban academic center. And they looked at 413 resident and medical students. And what they did was they basically randomized them to 1 out of 2 vignettes about the same patient. And the patient was a sickle cell disease patient. They either got a vignette about this patient that used neutral language, or they got a vignette that used more stigmatizing language. After they read this vignette, they gave the participants a survey to assess their attitudes about the patient. And they gave this survey to the students and the residents. And then they also asked just the residents to make some treatment decisions based on the vignettes. The study showed that, as you know, not surprisingly, that the students and residents had more negative attitudes about the patient in the vignette with stigmatizing language. And also the residents created less aggressive pain management plans for the patients in the stigmatizing language vignette. So they're more likely to treat the patient with the neutral vignette aggressively. They concluded attention to language used in the medical record can help promote patient-centered care and also reduce healthcare disparities for stigmatized populations. The next study we looked at, titled Physician Use of Stigmatizing Language in Patient Medical Records. This was a qualitative study at an urban academic center. They did a linguistic analysis of 600 outpatient IM notes among 140 physicians. Their goal was to identify the EHR language that reflects negative attitudes towards patients. So some of the themes that came up, they're basically trying to categorize like the negative themes. The first one was questioning patient credibility. So for example, how many times have we seen quotations used in the EMR? So they would look at the notes and see words in quotes such as supposedly, claims, insists, and they kind of categorize that under a question, like kind of a way to question whether the patient was credible or legitimate. In addition to the use of quotation marks, we've all seen kind of like some of the words that we use to negate what patients say. The second theme was disapproving of patient reasoning. So saying something like, unfortunately, she neglected to refill her blood pressure medication over the last week, or she's still not interested in physical therapy at this time as it's, quote, too much walking, or I again explained. So we saw the word again earlier in the example that Dr. O projected for us. And this language kind of implies tiresome repetition and a patient who's just unreasonable. The third theme we saw a lot of was stereotyping. So there was a lot of racial or social class stereotyping. A physician would often, they would see kind of quotations of incorrect grammar or simplified medical terms that scream stereotyping of certain groups of patients. The fourth, portraying the patient as difficult. So saying things like the patient was adamant about the following is something we've all definitely seen in our notes. And finally, emphasizing physician authority over the patient was another category and theme that they kind of categorized these records into. So an example of that is paternalistic language. I've instructed her. I have, again, said to the patient, and this kind of upholds the image of authority over a patient who's uninformed or ignorant. So they concluded in this study that these findings suggest that increased physician awareness when writing and reading medical records is needed to prevent the perpetuation of negative bias in medical care. The next study that was very relevant was titled Words Matter. What do patients find judgmental or offensive in outpatient notes? This was a study looking at 23,000 adult ambulatory patients in 3 hospital systems. And they did a thematic analysis quantitatively and qualitatively. Their goal was really to understand how many patients feel offended due to something they read in their notes, especially now that they have access to them, and why do they feel this way? So overall, greater than 1 in 10 patients felt offended by something that they read in their notes. So that's 10% of the patients that you're seeing. The general themes for what was offensive were errors or surprises, kind of things that weren't discussed, 2, labeling, and 3, disrespect. Now, on a personal note, I am currently over 8 months pregnant. And I will say that every single time I look at my chart or an ultrasound or something, and it says that I am advanced maternal age and geriatric pregnancy, I do kind of feel like a little like, hey, that's not nice, so, and I'm a physician. I'm not in poor health, thankfully. I am employed and I'm kind of able to work these days. This is just something to kind of, if it hits home for me as a physician, imagine how it feels from the patient perspective. They found that it was more likely to be the case if the patient was in poor health, if they were unemployed or unable to work. So these are just some things to think about as you complete your documentation. And now I will turn over to Dr. McLean.
Thank you, Dr. Nassef. So at this point in the talk, what we wanted to do was transition into providing a framework to stop microaggressions and to mitigate the harm that might be caused by microaggressions. And one of our goals is to provide some very specific, tangible and actionable recommendations that you can implement into your note writing and your note reading today. But we also want to provide some bigger picture recommendations that address the underlying problem, which is our personal biases. And then, of course, because this is CORD, we want to provide some recommendations for how we can teach our learners to avoid microaggressions in the electronic health record and to know what to do with them when we see them in the EHR. So, fortunately, there was an article in the Journal of Infectious Diseases by Marcelin et al. In 2019 that provided a really great framework for addressing microaggressions in healthcare. And it looks at our personal biases and our daily practices. And they kind of break it down into what to do before the microaggression occurs or is written or read, and then what to do after the microaggression is essentially occurs. So before the microaggression, we want to be aware of our biases. We want to be systematic. And by that, I mean using concrete guidelines or checklists and being very transparent in decision-making so that we never let something slip through the cracks. And then thirdly, to be open to new experiences and to learning about different identities and about people who are different from who you are. And then the second section of the framework is essentially after the microaggression. So their recommendation is to think about the intent of what you typed or what you did versus the impact of what it had, because sometimes those two concepts can be at odds. Also owning your own actions and acknowledging when and if you were biased or made a mistake. And then thirdly, reaching out to correct any issues that you may have caused to rebuild that trust, because that's extremely important as well. So the first portion that we want to talk about from that framework is just being aware. Be conscious of your personal biases, put some thought into recognizing what might be a microaggression in the electronic health record, and be aware of the presence of these microaggressions, both in the notes that you're writing, but also in the notes that you're reading. And just, be aware that those microaggressions can lead to propagation of this bias. And, just having that be a little bit of a red flag and recognizing a microaggression when you see it, that can help you avoid, having such a large impact of those microaggressions on your level of bias when it comes to taking care of patients. When you're reviewing your patient's notes the prior notes in their EHR, before you've even gone in to see the patient, whether it be from a prior visit or from a triage note, you have got to be aware that your perception of the patient may be altered even before you have met them. And that's kind of what I was alluding to a second ago. But on the flip side, get to know some of the more common microaggression related words, phrases, even the punctuation, the sentence structure that Dr. O was talking about before. Be aware that those are the things that can end up in the electronic health record, and that you can avoid putting those in your own notes, but also that you need to recognize them when you see them in other people's notes. Most people who incorporate microaggressions into their patient notes either don't know they're doing it or don't realize that it could have such a negative impact. I mean, we've got to think that most of the people in our profession and in medicine are doing it for good reasons. So most of the time it's unintentional, or they're just, using the same medical language that's been used for decades and decades. And it's just so hard to change that language, even though some of that language is becoming more and more like a microaggression. So how can we figure out our tendencies towards writing microaggressions, and how can we assess our own personal tendency to incorporate them into our patient's medical record? There are some very interesting free online tools that are available, that some of which are already evidence-based, if not completely perfected yet. And some of these tools were created for general writing, but some of them were created for specific kinds of writing, like recommendation letters. This one was created originally by Thomas Forth for recommendation letters or job postings. In this study of chemistry and biology faculty job applicants, text analysis software was used, as you can see here, to examine about 900 letters of recommendation for applicants to these fields. And they looked specifically at gender bias in the recommendation letters. So they found that relative to male applicants, the female applicants' letters were more likely to contain more grindstone words about working very hard and working continuously. And they were likely to contain fewer standout adjectives like exceptional, and remarkable, and also fewer ability words. So that was a pretty interesting finding. Other tools, like I mentioned, are for any and all narrative text. This is one of many sentiment analysis calculators that are available for free online, and I have plugged several of my HPIs into here, and it tends to be really eye-opening. I would definitely recommend doing it a few times and just seeing where you lie on the polarity analysis. Like I just mentioned, this one is specifically for polarity analysis, which is whether the text is written in a positive or negative light. It's one of the many types of sentiment analysis. So what I did here was I took that the HPI from our intro example and pasted it in here, and you can see that it calculates out to a negative polarity analysis, and their confidence level in that is 93.4%, which is pretty darn high. So with all the microaggressions in here, it's comforting to know that the calculation is as we expect it to be. While this type of tool will not pick up or highlight our specific microaggressions, at least not the ones that I have found online, you will at least find that the more microaggressions there are, the more negative that polarity analysis is. So what we would recommend doing is just taking even some of your old HPIs, like if you're worried about PHI, then you can de-identify them and then paste them into these kinds of tools, which if you just look up sentiment analysis or polarity analysis calculator, you will find it even if you just Google it. They're free as well, although there is some software that you can download if you're wanting to take a little bit of a deeper dive into your own patient records. So those are just some of the very specific recommendations that we have for note writing and reading. But what about the bigger problem, which is our own personal biases that contribute to microaggressions in the first place? So this is a big one. We really need to be aware of our implicit biases. And this is one thing that I just love speaking on, because I know that I myself am fallible to all of these implicit biases. And that's, you know, the fact that I know I'm fallible, I recognize that as a step in the right direction, because we all are. And the first step is for us to take a look deep inside ourselves, do something like taking an implicit association test, which you can find through Project Implicit. If you just look up Project Implicit IAT or implicit association test, you can go through all of the different options that they have and really learn quite a lot about yourself. it's pretty eye-opening, and it gives you a nice little breakdown after you've taken the test of where you fall on the spectrum of implicit bias, whether it's a positive or a negative association. Plus, it's just really fun. It's a really fun way to figure out things about yourself because it's a game. It's a fast-paced sorting game. I'm betting that a whole lot of the people in the audience already know about this test. So I would definitely recommend that you do some of that. Then there's this other concept. This is a trick that I learned from a mentor of mine, and I've tried to incorporate it into my daily practice whenever I'm on a clinical shift, or even if I'm, at the grocery store. There are ways to incorporate this trick into your clinical practice. So when you have finally become aware of your biases through means such as the IAT with Project Implicit, it makes you better informed to make good clinical decisions for your patients. It makes you better prepared to have a fair interaction with your patients and to let them show you what they are like, rather than just, making a judgment about what they're like based on what somebody else tells you or what you read in a prior patient note. But what about those times when it doesn't have so much to do with an implicit bias you might have against a specific group of people, but you have this preconceived notion about the patient? Like I said, we can really have our perceptions altered by what people say in the common spaces of the emergency department or the hospital, or even in the elevator of the hospital. In this case, this is where I use this trick, because the awareness that you're about to step into a situation where you yourself, you know that you are biased, it helps to be aware of that. Your perception of the patient may be tainted by the prior notes or by conversations. So for me, when I recognize this happening in my head, when I'm about to go into the patient's room, what I do is I take a mindful 5 to 10 seconds when I see this curtain closed in front of the patient room. And I know that when I open that curtain, I want to have as little of the prior, preconceived notions about the patients that I may have gathered in the moments leading up to seeing them. I want to expel that all from my mind. And I take a big, deep breath, and I try to tell myself, I'm going to let the patient show me who they are. I'm checking my bias at the door to the exam room. So that's kind of what I do. I see this curtain, and it's a reflex at this point because I've done it so many times. I just have that be the signal to my brain that I'm going to take that 5 to 10 seconds, and I'm just going to try and leave all of my bias at the door. As impossible though it may seem, I do as much of it as I possibly can. So. All right, the next thing is to be systematic, like we talked about. When you're writing your notes, check yourself on those microaggressions. Do it the same way every single time, almost like have a checklist that you go through every single time so that nothing slips through the cracks, so that you're checking your narrative writing every time. Be aware that there are sections of the HNP that might be higher risk of microaggressions than others. And a really good example is the one that we just saw with Dr. O. So you've got an HPI here, you've got a set of information for prior medical history. And you can see how, in the HPI, it's a little bit more of a narrative section. And those narrative sections tend to be more high risk for incorporating microaggressions because it's all free text. It's all the way that we type. And so if we have those biases, it's more likely to translate into a microaggression typed in the EHR. Now for prior medical, social, surgical, family history, it's still possible to have microaggressions in those sections. And the reason being that right now, our ICD-10 codes even have some microaggressions in them. Now it's maybe getting a little bit better every version of ICD-10 that we advance, but there are still phrases like IV drug abuse, alcohol abuse, homeless. You know, there are qualifiers for non-compliant with medications on those ICD-10 codes. So if the patient has previously received a diagnosis that has what is by the layperson interpreted as a microaggression, then those could end up in those sections. So just be aware of that. And if you see one that you really have a problem with, or that really seems to be high risk for propagating bias and causing harm for the patient, then I would actually go to, I would give medical records a call, or ask them if there's a way to remedy that. Or if it's something that has just recently been documented in that same encounter in the emergency department, say by a triage nurse or a charge nurse or the patient's nurse, then see if they can correct that and get it to a little bit more of a neutral term. All right. The next thing that I want to talk about is this framework that we created for assessing the level of risk for microaggressions in different sections within the electronic health record, specifically in H&Ps for the emergency department. So these are the sections that we're looking at. They are color coded by our perceived risk of microaggressions being incorporated into them. So you can see that here, the green CC, the chief complaint, it is still possible to have some microaggressions, but the risk tends to be a little bit lower because the chief complaint is supposed to be in the patient's own words. But like I said, if you see something in that chief complaint that you don't think belongs there, that the patient would not have said, then you can have that corrected if you just go talk to the charge nurse or the triage nurse. Then we get to the HPI, history of present illness, which we were talking about just a couple of seconds ago. Like I said, this is a red flag. It's a very narrative section. The risk of incorporating microaggressions into here is pretty high. So be really careful. Then we move on to the review of systems. And of course, like we rated it as a green because it tends to be check boxes, positives, negatives. It is still possible to incorporate microaggressions such as substance use if you are reviewing the psychiatric area of the review of systems. But the risk is a little lower because it's not so narrative. However, when we get to the prior medical history, like we were talking about just now, it is possible that some of those ICD codes end up being a little bit worse than neutral and a little bit more of a microaggression than we would like. So that is why we gave it a yellow flag. Meds, allergies, not quite so much of a issue there. But again, if there's something in there that doesn't belong, then you can always go to medical records or the charge nurse. The exam, we call that a yellow flag because it's a little bit more narrative than some of the other sections, but it's not quite as narrative as, say, the HPI or the MDM or the discharge instructions. So we will give it a yellow flag, but it is possible to incorporate microaggressions such as, I think Dr. Nassef mentioned it before, but you know, patient adamantly refuses pelvic exam, or patient is, you know, geriatric pregnancy patient. There's so many different possibilities for things that could be incorporated into exam, but a lot of times those tend to be check boxes as well, so a little bit less likely. Results, fortunately, are something that we don't have too much control over if we're just populating the lab results and the CT results into our EHR. But if you happen to see something in, say, the radiology, the reading radiologist's narrative report of a CT scan, if you don't like it, you can also reach out to them and see if it can be remedied. Next is the medical decision making. This is another red flag section, and mostly because it is narrative. Diagnoses, we talked about this in the prior medical history section. We also call this a yellow flag for the same reasons. And then for those personalized discharge instructions, this is a special case because these are given to the patient, and they are, you know, a lot of those narrative discharge instructions that we type up specifically for this patient regarding this specific patient and what we did for them in the emergency department, you can see how those would be more prone to microaggressions, especially if you tend to type up longer discharge instructions. Be careful. Some practitioners tend to use this as an outlet for their frustrations with the patient. But remember, it gets handed to them directly. So as a general rule, you should never document with emotion, especially not with a negative emotion, because this will cause you to inadvertently or advertently type in some microaggressions into their electronic health record. And this is kind of a double whammy because it both ends up in their EHR and you're handing it to them. So it's kind of like that email that you should never have sent that you typed up while you were really, having some strong emotions. So just be really careful with those. This is another time to take a mindful 5 to 10 seconds before you type something up, or even to have a friend that you run the discharge instructions by, somebody who you're working with alongside them in the department, and just have them take a look at it and give you an unbiased second opinion about the notes before you hand them to the patient. All right. Now, like Dr. O promised, we are going to go through some of the specific microaggressions that that you all were able to identify in that in the example scenario that we talked about in the very beginning of the webinar that we're getting. So, noncompliant, he mentioned that this can be a little bit of an inflammatory phrase for patients to read if they're accessing their own EHR. Instead, use a phrase like does not adhere or unable to adhere to their home medication regimen. Instead of patient refuses, use something like patient declines. It may not be that they're refusing so much as they're unable to agree to something like a pelvic exam or a rectal exam or something that's sensitive to them for some reason. Morbid obesity, this is becoming a little, this was definitely historically a very well-known medical term, although Dr. O did describe what it means for the layperson, and it does have a very negative connotation for the layperson, even if you look at the Merriam-Webster definition. So instead, we're using different descriptors like severe obesity, or a lot of times in my patient notes, I just say elevated BMI or severely elevated BMI instead of even using the word obesity. It can be quite a sensitive subject. Instead of phrases like patient admits to this or that, say the patient states, because admitting to something implies guilt. Patient insists on something. This is another one that you have to be really careful about. Instead, just say patient states. There's no reason to use the word insists. Allegedly implies that there's some kind of a legal proceeding going on and that what they're saying may not actually be true. If you received a report about something that happened to the patient from someone else, like a police officer, then just use the word reportedly instead of allegedly. Complains of, this is a really difficult one because a lot of people just use complains of in every single patient note that they write. And historically, it's another one that's been commonly used in electronic health records. Instead, use phrases like patient is concerned about. Instead of words like homeless, which used to be historically maybe not quite so much of a microaggression, now it is tipped over into the realm of more of a microaggression and a little bit less PC and a little bit more offensive when patients read it. So some alternatives to this are unsheltered, houseless, unhoused, or even currently without a house, something like that. All right, we'll address some specific recommendations for patients who have substance use disorders. And this table is adapted from the National Institute on Drug Abuse from a November 2021 article entitled Words Matter, Terms to Avoid When Talking About Addiction. So the goal when we're talking about patients who have substance use disorder is to specifically document encounters in a way that uses clinically accurate and non-stigmatizing terminology. The same way that we would use that terminology for somebody with any other medical condition like hypertension or high cholesterol. It's just another diagnosis, and we should be treating patients who have substance use disorder with the same respect and using the same or similar descriptors for their disorder. So try to avoid eliciting negative associations, punitive attitudes, and individual blame for folks who have substance use disorder. For example, the term abuse has been found to have a high association with negative judgments and punishment. And this is per the National Institute on Drug Abuse. It's kind of funny that I just said that. I don't know if you recognize the irony, but it's the National Institute on Drug Abuse, and their own recommendation is that you don't use the word abuse. So, all right. We're going to talk just for a second about word systems, specifically content and structure. So the most studied example of word systems and specifically content and structure is this person first language. Patients are people first, and their diagnoses come much later in the descriptors in the sentence. Saying that somebody is a 40-year-old male with a diagnosis of diabetes has a much better connotation than saying they're a 40-year-old diabetic male. So even though it takes a little bit longer to type out the full sentence without having the diagnosis first language, we do believe that it's well worth it in order to reduce the microaggressions in your note. Some of the other points here were alluded to previously as well, including irrelevant information where it doesn't belong, or even omitting important information where it does belong can be interpreted as a microaggression. Some examples are including race or ethnicity in an MDM one-liner when it plays absolutely no role in the medical pathology or the treatment plan. No, you can make the argument that it does in some select cases, but it's not something that should always be included because it could be interpreted as a microaggression. The other example is omission, like I said, of important information such as the transition status of a patient who is transgender and who comes into the ED with a GU complaint, or for which that information is crucial in their medical care. So omitting something and just not even asking or not even checking isn't just a microaggression, it's actually also downright dangerous. So you need to have those conversations with the patients, you need to do your due diligence and make sure that you're covering all your bases, and also don't omit that important information whenever it really belongs in the EHR. Another one that we'll talk about that is it's kind of a, the quotation marks is the next one. Now, this one is so bad sometimes that it's almost funny, but it's like so bad that it's not funny. I mean, there are places in the EHR where quotation marks can belong, such as, you know,
you can log into the licensure.
I'm sorry, one more time.
I think it was just a mute error.
Okay. So there are times when quotation marks do belong in the EHR. You can make an argument for it. So such as an example I've heard recently from our own PD is sometimes they use quotation marks to describe what the patient is saying. If it's something like the patient says, it feels like an elephant is sitting on my chest. If you feel the need to describe what a patient is saying in their own words, then that can be an appropriate use of quotation marks. But there are other times when using quotation marks is a pretty overt microaggression. An example being, patient states, I was minding my own business sitting on my front porch, or something like that. something that doesn't really, like, you can kind of recognize it when you see it. It doesn't really belong there. But if you're truly just trying to quote the descriptor that the patient is using, that can be appropriate. You just have to be really careful with it. And then the last one that I'll address is just repeated instances of patient states, patient says, patient reports. A lot of the medical scribe training these days does teach them to document in that way, just because it's a little bit of it's been seen as a defensive way of documenting. However, if it's literally every sentence in your HPI, that starts sounding like you don't trust the patient, or like what they're saying is not necessarily true. Because if you're saying the patient states this, the patient reports this, there is a universal understanding that the HPI is the patient or the family member's subjective report of what's going on anyway. So there's no reason to kind of double up on that verbiage and just like repeat it every single time you type in a sentence. All right. And then the last recommendation in that framework that I presented in the beginning of this section of the talk is just to be open. Be open to learning about new people, new cultures, conditions you don't know about, etc. There are media resources to help with this, but just remember that there's no substitute for getting to know actual people and learning about their struggles and what it's like for them. Try to put yourself in their shoes to build empathy. And part of the goal with this increased understanding is avoiding getting into a place where you have negative emotions while you're documenting. It's hard to document objectively when you have strong emotions one way or another, whether it's positive or negative. And as a general rule, emotions, especially negative emotions, just don't have a place in the EHR. And then when it comes to teaching our learners these skills, don't forget, this is something that they need to learn. And it's not always intuitive. It's something that a lot of us are just starting to think about more and more these days, even in the attending world. So they need lessons on this, the same as we teach splinting, central lines, physical exam skills, etc. So one easy step is to send them the recording of this Cord Connects when it's released. Send it to your learners, to your residents, your med students, your coworkers, but also you need to have these conversations with your learners when they're on shift. If you're working with a resident or a med student and you see a patient who you yourself find to be a little bit challenging, chances are that other members of the team are having some of the same emotions as you are regarding this patient. And acknowledging and taking the time to discuss that with your learners and with other members of the team is a really good way to prevent documenting microaggressions related to those emotions that you're having, and to teach them to kind of pick apart and unpack these emotions in the future before they start typing up a storm in the electronic health record. Furthermore, this is something that we oftentimes forget to do for our residents and med students. They need feedback on their patient notes. So take the time to read through a few of them and give them some candid feedback. Pick out the microaggressions if you see them there. And even though it may seem nitpicky to them when they receive the feedback at first, just back up why you're saying that it's a microaggression and try and, have them put themselves in the shoes of the patient, how it might be to read that in a patient note if they access it via their patient portal. Make a point of doing this for both some run-of-the-mill encounters like chest pain or headache, but also do it for some of the encounters that you and your learners find challenging, especially if they were challenging for reasons having to do with an implicit or explicit bias. So here is our mess of good references we would recommend everything on here. And we wanted to say a big thank you to Cord Connects for having us. And also thanks to everyone in the audience for coming out.
Amazing.
I'm trying to figure out, very well done. I'm trying to figure out the fancy way of raising my hand here, but I'm failing. Oh, look at that. As you approach, a new class in July, when and how do you approach this topic with them? Because we can assume they've all been taught poorly, and we are now going to be responsible for teaching them appropriately. Is this something you put in the intern orientation? Is this part of your residency didactics? Like, do you rely on it being a at the bedside clinical kind of people are going to look over the notes? What do you do?
It's a really good question. I was wondering if maybe I do have an answer from the teaching residents perspective, and I'm betting that Dr. O and Dr. Nassef have an answer for it from both the resident teaching perspective and the medical student teaching perspective. I'll go ahead and say, like, we had this discussion in our intern orientation this morning. So, I mean, it wasn't this entire talk. I'm sure that, at some point this year, I'm hoping that we can give this talk to the entire residency. But today, I did like a 6-slide version of this talk for our interns, and it was really well received. Lots of questions. I mean, I think it's a good time to do it like during orientation, because everybody is absorbing everything around them. They know they have a lot to learn, and they're about to start documenting in the patient's permanent EHR. So I see it as a really appropriate time to do it right now, right after they arrive at their new program. And we're in the second day of orientation right now. And then the other thing that I try to do with them is once at the very beginning of the year, like the first 2 months or so of after interns matriculate into our program, I try to email them some detailed feedback on at least one patient note that I read through as I'm co-signing and find a couple of things that I would do differently for this and that reason. And I find that tends to be really well received feedback. And a lot of times they haven't received very much feedback on their notes in the past. And so they tend to be pretty appreciative, and it tends to be pretty eye-opening, I think, for them. So
I definitely agree with Dr. McLean in terms of, at least with the residents, just kind of reviewing their notes, reviewing their discharge instructions is something that I kind of take to task every shift that I work. And I'll tell them, I'll say, don't click discharge until I can see your discharge instructions. And they really appreciate it. They're like, no one's ever, looked at my instructions before. From a medical student perspective, and actually also from a scribe perspective, for the medical students, they're not documenting in our EMR, but just kind of hearing the presentations and paying attention to what they say, they're saying what they overhear. So they will sometimes present patients in a very, in a way that's, that's kind of loaded with microaggressions. So correcting them early on and often is important, so that when they do transition to residency, they're more equipped to, keep the microaggressions out of the EMR. And our scribes, when I will tell them, to kind of change the language a bit, that, like Dr. McLean was saying, using the words like admits to or non-compliant. A lot of times you'll see things like frequent flyer in there. So I'll just correct the scribes. A lot of them are going to be future medical students or future, non-physician practitioners. So there's always opportunity to kind of get this teaching in. And I find that the more I tell the residents, the more it improves with time.
Maybe one last question. Do you have recommendations of where people can keep up with this? So I feel like many things in the space of microaggressions, language is changing, and what's considered okay now or what was okay previously is not okay now. Like what's a good place other than sort of attending talks like this on just kind of keeping abreast of language change, basically by some of the things that we've done by, for years, like morbid obesity is, I think, a really great example of that.
So to my knowledge, there is no medical community specific like bank of words that are appropriate and not appropriate. I wish there were. And I bet that over the next 5 years or something is going to become available. Now, there are some diagnosis specific guidelines through such organizations as the National Institute on Drug Abuse. And once in a while, they come out with new articles about what's appropriate to use in this context and what's not. There's also, in our research for this talk, we also found several like guidelines for media outlets on how to portray people with different diagnoses if you're talking about them in the media. So that's something that there's quite a lot more recommendations out there on the internet if you look for it, but a lot of it is not evidence-based. If you really want to get down to the nitty-gritty like literature, then definitely the types of studies that have been coming out over the past 4 years or so that Dr. Nassef was reviewing, those are some really good bits of primary literature that you can take a look at. And if you do a little bit of a deeper dive into the actual methods that they use and their experimental setup, they will point out some of the specific microaggressions that were interpreted in an offensive way by the subjects who are patients. So.
Okay, thanks. I think there's one question, and maybe we'll have this be our final one given our time. Is it Dr. Effion?
Yes, thank you very much, Dr. McLean and Dr. Nassef. So I want to say microaggressive words, yes, they are really a thing. I see it a lot as well. And sometimes, unfortunately, people actually make fun of it when they see it. So Dr. McLean was saying to be a good thing to actually teach all the residents, like present this topic to all the residents, and I really agree with her. I feel it to be very helpful to do it during our noon conference. Apart from the incoming class during orientation, I feel during one of our noon conference, even if it's pre-recorded and people are required to attend in person, because I believe this is very important and everyone needs to hear.
Thank you so much. That's nice to hear.
Absolutely.
Thank you.
Great. So thanks everybody for being here today. And thank you to our speakers. It was really awesome. And stay tuned for our next month's agenda. We're still planning what that talk will be, but we'll be communicating through the cord communities. So thanks everybody and have a great day.
Thank you very much, guys. Well done.